Welcome, everyone. Thanks for tuning in today. I am Linda Thompson, Dean of the College of Nursing and Health Sciences at the University of Massachusetts, Boston. For those of you in the audience, you can see and hear us, but we can't see or hear you. I want to start by saying that I hope all of you are healthy and doing well. And to those of you who suffered from the virus itself or have a loved one that has been impacted, the thoughts of the entire campus community are with you. I want to thank all of our incredible graduates and students who are on the front line fighting this disease. I'm so proud of you, grateful for you, and impressed by the work that you're doing. Today is the first day of National Nurses Week. It is also the year of the nurse and the 200th birthday of nursing legend Florence Nightingale. This program today is one of a few that was planned for nurses as we were hosting Nurses Week. We have planned many events for this week, but we have postponed many of those until we're able to return to campus in the fall. Today, we'll be talking with some of the University of Massachusetts Boston's outstanding alumni who will share their perspective on the evolving situation and their experiences with COVID-19. I thank each of you for being here today. We look forward to hearing from you. I just want to share a little bit about what's going on at the University of Massachusetts Boston and the College of Nursing and Health Sciences specifically. In March, UMass Boston moved to remote learning throughout the entire campus. Students are receiving remote versions of full range of our academic offerings. All of the service tools were enabled for them to complete their spring semester and receive credit as they move towards their degree. We continue to offer services like health and wellness, counseling services, library services, and tutoring. We're offering courses during the summer, and we have been fundraising to, and the courses this summer will be discounted. We offered Chromebooks to students who didn't have a computer, and we continue to fundraise to provide aid to our students. UMass expects to receive about $12 million from the CARES Act, and 50% of those dollars will go to provide financial support to students. With so much unpredictability, we are busy trying to plan for the fall semester, whether it's going to be online, remote, or in classrooms. We're really trying to do what's in the best interest of our students. In our college, we transitioned all of our clinical courses to a remote learning modality. That was, and I'm so proud of our faculty and our staff who worked almost night and day trying to identify materials that would be supplementing their experiences that they would have received in a clinical area. And prior to us going remote, our college moved to a new space in the Quinn building. We opened up our Center for Clinical Education and Research that now houses our nursing lab. The Quinn building now houses our exercise and health science physiology lab and a simulation suite. We have exam rooms and a computer lab, and we look forward to when we get back to campus that you can come and visit our new facilities and take a tour. So I hope you're able to join us. I now want to turn my attention to our panelists. We will chat with each one of them, and they will answer some questions that you've submitted. Our panelists include Dr. Joseph Francisca. He's the Chief Medical Officer and Head of Research for the Americas for Philips, and he's also the Vice President. Dr. Rhonda Hodge, who is a provider and practice owner at Harmony Psychiatric Services, Valerie Joseph, a nurse practitioner at the Whittier Street Health Center, Faith Karoma Coker, who's a certified nursing assistant at Boston Medical Center and a current undergraduate junior nursing student in the College of Health Sciences. Donna Marie McGuire, who's a senior clinical compliance consultant at Brigham and Women's Hospital and president of the UMass Alumni Association. And finally, Dr. Tim Quigley, who's the vice president of nursing and he's the vice president and chief nursing officer at South Shore Hospital. Dr. Quigley is in a meeting right now, but he's going to join us as soon as he's out of his meeting. So first, I want to start with Dr. Brasiska. Let's start with you. First, I know that you are just so busy during this time, and in fact, we'll have to hop off of this call at 2 o'clock because you're starting another meeting. And we appreciate your taking the time out of your day to be with us this afternoon. Can you tell us a little bit about what Philips is doing and how you've made adjustments in your work and your role?
Well, Dean Thompson, thank you for inviting me. This is a great opportunity to talk to people from UMass Boston, and hopefully we'll get a chance to share our experiences here over the next few minutes. My work has changed dramatically in some ways over the last few months, and in some ways we continue as usual. First, I completely identify with the changes that are happening in education. I'm on the faculty at MIT, and early March, we were confronted with this issue of how do we transition courses, our course in computational physiology, to remote sessions. This is a laboratory-based course, and I'm sure you identify with these issues. How do you deliver education at a distance? I think what we missed most, though, was the nature of the contact with the students, over the last few months. And so we've had a little bit less direct face-to-face time with the students, but we've been creative, and I think students have gotten good educational experience out of the program. So my hat's off to UMass Boston in transitioning as well. It's been a tough road for education, I think. Mm-hmm. Our innovation teams at Philips have been working overtime since the beginning of this crisis to drive innovations aimed at COVID-19. We're accustomed to working in a global setting, though, and working in virtual teams that span the globe. So the concept really isn't new that we have to limit our face-to-face contact, but it's just become more acute. So it used to be that we did see each other every once in a while. Now we're not seeing each other at all. But we've transitioned mostly to working remotely, with the exception of some who still work in the lab, and using tools that everyone's getting used to, like Zoom and Teams and other video chat capabilities. Lab functions much the way it has, though, with conferences and team meetings and check-ins, et cetera. Everyone's sort of juggling all of this with their additional responsibilities, of every day, being school teacher and principal and referee, et cetera. So it's a challenge for our research team to work at home when school is up, but they're doing a great job, I think. Along with our businesses, we recognize the need for additional technologies that this crisis would present early on. And one thing that we're particularly proud of is that we went back and looked for ways to increase the availability of ventilation, because early on in the crisis was a worry about how many ventilators would be available for treatment of patients. Philips redesigned our CPAP and BiPAP machines in the course of 3 weeks and created an inexpensive ventilator that went into production, is now moving into the community, and we're ramping up to create 64,000 ventilators a month. That's amazing. These are simple ventilators. They're used, for emergency situations, but they are ventilators and technologies that are reliable and safe. So I think that's something that we're looking back now on that 3 week period and wondering how we accomplished it. we also recognize the need for sorting through all the different new ventilators that are appearing in our ICUs. So at Mass General, we have, maybe 5 or 6 new ventilators in each ICU that no one recognizes. And, the word is out, don't touch those ventilators, even more so than before. Used to be, we were told, please don't touch the ventilators, but everybody did. And now it would be dangerous for us to touch a new ventilator that we've never seen before. So we actually recognize this as a problem and joined with all of the major ventilator manufacturers and Allego. And they're distributing operating instructions in a downloadable mobile application called the Ventilator Training Alliance that is online now. And I don't know if people have seen it, but we've had 30,000 downloads in 158 countries across the globe. And virtually every ventilator on the planet, the use instructions are included in this application. So it's quite an accomplishment, and really an example of reaching out and helping across potential competitors, and to address the issues of this crisis. So we're also working on ways to predict who will develop infectious disease. So over the course of the last 2 years, we developed an algorithm that with the US government that would help us to identify patients who are coming down with an infectious disease generically. And our algorithm has pretty good performance in the hospital setting, so we can identify patients who are going to be infected about 48 hours before there's a clinical suspicion, utilizing some pretty standard measures. And we're expecting to expand this to ambulatory setting. Imagine if we're able to identify patients who are about to develop overt symptoms of COVID-19, but haven't yet. And they could then self-quarantine, and you'd have a chance, before they have a chance to infect others. This, of course, would reduce the R0, which is the number of people who are infected by an infected individual. So if we could dramatically decrease the R0, we could actually decrease and slow the spread of the virus. So we're hoping that works. We're in a clinical trial right now that's ramping up. And if we're able to predict who is going to be infected, that could be a big step forward for prevention of disease. Over the course of our hospital-based activities that aren't direct patient-facing, so all of the hospital-based activities that we have within the hospital, and I'm sure, Timothy, you have the same issue. All of our conferences and meetings have moved to Zoom now. So this has limited the direct interaction of all of our hospital staff together to try to limit the spread of the disease. There's one bright side to this that I want to point out that I recognized immediately when we created our weekly conference in the ICU as a Zoom conference. We have a higher than usual attendance. People are able to get to it because they can sign in on their iPhone, or they can do it from where they stand and not have to, make the walk over to a big conference hall. So our hospital-wide meetings are even more accessible than ever. So I think that's a big step forward, and something we may never go back on. So we'll talk a little bit about that later, but I think we're learning a lot here, not just about COVID, but about how people work together and support each other. And I think that's something that we can all be happy that we've advanced quickly in this crisis.
Sure.
So that's about all I have to say at this moment. So thank you for.
Oh, thank you so much, Dr. Fristica. What do you think the near distant future looks like for your work or for the industry in general? How do you think it will be different as we move forward?
Yeah, so lots will change. I think. I think first our recognition that we need more resources in the community is going to be obvious, right? So over the past 10 years, we've been working at trimming the capacity, trimming ability for or costs in the community. So community hospitals have closed, other settings have become smaller and downsized. We moved a lot to the ambulatory setting. I think there's a balance to that we now recognize that we've never seen before. So in this downsizing and moving everything to the ambulatory setting and decreasing the ability for hospitals to ramp up, we have created some some crises in this big pandemic. So I hope that we are able to, after this is over, dispassionately look at our capacity and make intelligent decisions on how we can rapidly ramp up capacity and not destroy capacity anymore.
Sure.
The second thing that I think is really, really obvious to me is that the use of telemedicine and the ability for us to see patients and care for them at a distance is quite obvious. We've known this, as a healthcare company and as a profession for many years, that telemedicine had great potential to make healthcare better and to extend the care to patients who normally wouldn't be able to access it. And we've been using it in rural settings. So for instance, with the VA, we just launched a program called Atlas, where we're providing telemedicine to VA patients in the community, in rural communities, through veteran service organizations and others. And that's been a success, but it's really been limited. Now consumers actually have had a taste of telemedicine. And so, getting routine care via telemedicine is pretty convenient. You don't have to take a half a day off and pay $20 to park in downtown Boston to go and see someone for a routine visit where there's not a lot of hands-on. It's really a conversation. So I think once consumers have gotten the taste of this and really, recognize the benefits of it, it won't be a theoretical conversation in Congress anymore. I believe it will be a real concrete conversation about how we move it forward. So I think telemedicine will get a big boost here, and for the good of patient care, I believe.
Oh, that's great. Thank you so much for all of the things that you're doing. Dr. Hodge, you are in the important field of mental health. Fear, stress, and anxiety about this disease, it can be overwhelming. Can you talk a little bit about what you're seeing, and are you seeing more patients now than usual? And how have you adapted the way you provide care?
Thank you, Dean. So I think everything has really changed. We had to decide pretty quickly to move all 500 plus of my patients to virtual medicine. It didn't make sense for them to be coming in. It's not, we kind of just spoke to that. It wasn't necessary. I didn't have to do hands-on, and I was able to kind of keep them safe, as well as the idea of them actually leaving their house during the time increased anxiety. So we weren't dealing with the base of what day-to-day looked like. I've been seeing, typically I see, let's say 10 to 15 patients a day. At this time, probably seeing 20 to 22 a day, sometimes more, and seeing patients more frequently throughout the week. And I'm not their therapist, but the therapist sees a patient for an hour and they can only fit in so many people. The base of what we're seeing is an increase in anxiety. The increase in anxiety comes from the base of the lack of predictability. And we don't know how long we'll be staying home. And we don't know what this is going to look like in a few months. Those transitions are hard for anybody, but it's extremely hard for people who have depression, anxiety, OCD. I think of some of my patients that I've been seeing that, our goal was to be able to get them out of the house and get them moving. Well, now they've been told by the world they can't get out of the house and they can't move. Mm-hmm. So a lot of my work has to do with being creative. I will take my patients on a virtual walk. I'll have them shut off their camera and we'll go outside and we'll walk, and they know I'm walking with them. We have virtual yoga at my practice now. We just have to really think outside the box. I'll send some of the kiddos a little gift so that they know that there's that connection. I'm working with a lot of people who are on the front line that were already my patients or they're coming on. One story in particular that really stands out to me is I have a patient who goes into the hospital and she works night shift. Well, at night shift, you can't go in the front door. You have to go in the back door. And if you go by the back door, you're going past the 2 freezer trucks because the morgue is full. So sometimes she will go into work an hour to 2 hours early so she can go in that front door because she can't. She tried, and they told her they really wanted her to try. And I said I would write a note, but eventually that was okay for her. that she'll just go in and scroll through her phone and sit in the room so that she doesn't, because she felt she was focusing on that when she was supposed to be focusing on her patients. And that's not someone who's on the COVID floor. My patients that are on the COVID floor, they're seeing, story yesterday, seeing one of their providers that they've had their whole life, that they just had to send down to the unit. So, I mean, it's everybody. It's everybody's transitioning, everything's changing. But one of the things about this trauma that I'm concerned with, as far as the people who are on the front line, healthcare workers, people working in grocery stores, all of that, is that it's not a trauma that lasted 1 day or 2 days or 3 days. This is prolonged trauma. I'm noticing that some of my patients are starting to no longer feel that anxiety, which means that they're kind of starting that disassociation period that happens with a prolonged trauma. So I think this is something that we're going to have to be working on for a really long time, and just being really creative about it.
Boy, this is just so interesting. So, Dr. Hodge, if there are members in our audience who are dealing with stress or anxiety, do you have any recommendations for them?
Absolutely. I've been trying to do some empowerment groups and and helping people with self-care outside of reaching out for care, but definitely reaching out for care. It was at the very beginning of this, a lot of places weren't taking intakes virtually. Some people are now. They can reach out to us. We'll set them up with wherever they need to be. But I would say just reaching out to people, starting these Zoom meetings with friends. There's a whole bunch of new apps that came up that are allowing people to still connect with each other. I think that's the biggest piece. And my doctorate was on getting your body moving and reducing the symptoms of depression and anxiety. Those things are huge. Just connecting with people.
Mm-hmm. Thank you so much, Dr. Hodge. Your work is so crucial, and so many people are feeling the stress. Valerie Joseph, our next panelist, is a nurse practitioner at the Whittier Street Health Center. Valerie, thank you so much for the work that you're doing. Current data suggests that there's a disproportionate burden of illness and disease among racial and ethnic minority groups. Can you share why you think this is occurring?
Well, hello, everyone. Thank you, Dr. Thompson, for having me today. Well, I work at the Whittier Street Health Center, which is a urban community. Minority groups have always had to deal with health disparities, and adding to the known history of racism affected it greatly. And pandemics like this, they are often due to the economic and social conditions. So, members of racial and ethnic minorities, they tend to live in densely populated areas, which make it very difficult to practice social distancing. And living below the poverty level, the stigma, the lack of health insurance, all this refrain them from getting access to care when they are sick. And also research has shown that compared to Caucasian, Black Americans, they have higher prevalence of chronic conditions such as diabetes, hypertension, asthma, smoking, obesity, which puts them more at risk for the coronavirus. And also compared to non-Hispanic whites, like most of African Americans or Hispanic, they're like essential workers. So can be from agricultural workers or healthcare workers like LPNs, nursing assistants, housekeepers, work at all the grocery shops, and due to the economic circumstances, most workers, they may need to continue in these jobs despite the pandemic, as opposed to being able to work remotely from home, unfortunately. So all of these have an impact to the urban community.
Mm-hmm. So you work for one of Boston's largest community health centers, Whittier Street Health Center is in Roxbury. Can you tell us a little bit about your day-to-day work activities?
As expected, our daily routine has changed tremendously. We have launched COVID-19 testing sites on Tremont Street now, Monday to Saturday, 3 weeks ago, which is a great thing because we have a lot of anxious patients. Regardless, they will just go for testing, and just to give them the ease, like to be at home and knowing that they don't have the virus, that really helps. And we screen and take everyone's temperature at the entrance, and everyone must have a mask on from now on. And all providers, we must wear the N95 mask to all day, strictly on site. And we promote frequent hand washing and try the social distancing as much as we can, which is hard to when we share like rooms with 2 to 4 providers. But overall, it's a teamwork effort. Most of our patients are scheduled via the telemedicine visits, although we have some patients, they still want to come for office visits for simple reasons as, oh, I'm still coming to the clinic to get my med refills. Why can I see you? Or I'm bored at home. I'm tired. I cannot stay home anymore. That's like a chance for me to come and see my doctor. We can chat, and like it's for safety purposes. It's best if you can stay home. We can just talk over the phone or even like a virtual visit. And we accept office visits for triage patients like that are negative from COVID-19 that may complain from some vaginal discomfort or some unresolved ear pain post-treatment. So those are the patients that will say, okay, come on in, because we need to do the physical assessment. And we check on our positive COVID-19 patients daily, which we have quite a lot because we work on the adult, mostly my patients are adult, elderly patients under clinic. So they positive. So we check them every day. And we advise some patients to get tested based on their complaints, but we keep pushing forward and pray God that this will stop soon.
Right. Everybody is doing that, praying that it stops soon.
Yes.
So Faith Coker is a certified nursing assistant at Boston Medical Center and one of our juniors in the College of Nursing and Health Sciences. She's one of our nursing students. Faith, could you share with us what your school experience was like before and how it has changed, and what is your job like now?
Yeah, definitely. So thank you for having me, and hello everyone. But yeah, so before this happened, I was in the classroom on Wednesdays for about 6 hours, and then I'd just do homework and other work in the evenings, and then otherwise I'd have my 2 6-hour clinicals. So I'd have my maternity rotation and psych rotation, which is what I'm in right now, on Thursdays and Fridays. And then I actually started working at BMC in January. So on the weekends, on Saturday and Sundays, I'd go and work as a CNA there. So as a CNA, I'm responsible for generally taking vital signs, ADLs, blood sugars, bladder scans, EKGs, and just supporting the nurse. But now that the pandemic has happened, during the week, I'm still in school mode and watching my lectures, studying for exams, and attending my online clinicals. And about that, like my professors have done a great job at just adapting to the situation and adapting to this like online modality. But otherwise, when I'm in the hospital, what's changed is I still have about the same patient load. So generally I have about 16 to 11 patients during my shift. And so my unit was originally an oncology unit. So there is actually a satellite location at BMC, and I have been floated there occasionally. But my original unit's location is now a COVID unit, and that's where I am most of the time. So during that time, we've definitely changed things. So firstly, everybody who goes to work changes into surgical scrubs. And in addition to that, we get our surgical caps, face shields, N95s, and just a face mask for when a face mask for when we're going into rooms as well. And we change that over our N95s. Also, something different that's changed in terms of my job is to decrease the amount of people we have going in and out of rooms, and also to preserve PPE. We actually have the nurses providing most aspects of patient care. So like things like ADLs for the most part, or even like blood sugars and vitals, like the nurses go in and try to do that, as well as like everything that they're responsible for while they're in the patient room. And I'm generally there to pass them things while they're in the room if they need it, or if it's a heavier patient or a patient that they need help with that they just can't do something alone, like I will go into the room to help them in that case. But in terms of our patients on my unit, they do have COVID, but they are pretty stable and usually just need supplemental oxygen. Something that we have been struggling with, I guess, at my hospital in general, I think, is especially just having patients that aren't mentally stable, or we've had a lot of patients with language barriers, especially for the setting, like it's a very urban hospital. And we do have a lack of translators right now just due to the pandemic and people being out of work. So like even last week in the break room, I heard nurses and we were just talking about like out of her 3 patients, like literally none of them spoke English. So that was very difficult. And you just find yourself in situations where, one, you're going into a patient's room a lot more than you would generally need to. But it's like once you're in there, you can't really understand what they need, but also they can't understand you and understand that, for example, they might need to keep their arm straight for the IV to stop beeping, or that their nasal cannula needs to stay on. So unfortunately, that's something that ends up resulting in spending a lot more times in rooms and using a lot more available PPE that's pretty valuable right now just for those brief trips to communicate and try to help the patient. But yeah, that's what it's like working so far.
Thank you for that. What were what were you and your classmates feeling when you learned you'd be exposed to and taking care of patients with COVID-19? And has this reaffirmed your desire to be a nurse?
So when my unit became a COVID unit, I definitely felt a range of emotions. Scared was definitely one of them. And in the beginning, like early March, I remember just having FaceTimes with a lot of my other nursing friends and just talking about everything and discussing our thoughts. And like, there were times in our discussions where like quitting did come up, or like taking time off. And like, even I considered taking time off, especially just because I like was in the process of finishing my orientation, but I just drafted an email and never sent it. Also, during that week, I remember talking to my mom, who's also a COVID nurse at BMC, and she actually just recently recovered from COVID and returned to work last weekend. But I remember just talking to her, and something that she emphasized, which like struck a chord with me, is I feel like as a student, especially because we're so close to the end and like graduating, at first your initial thought is, should I quit because my end goal is like to be a nurse, or like, and she was just talking about how like quitting might feel easy just because I see my current position maybe for me as being temporary. I'm looking forward to the future. But she brought up like, if I was a nurse, regardless, like I'd still be in the rooms, I'd still be interacting with patients, like no matter what your position is, whether you're a nurse, you're environmental services, you're a doctor, like whatever, like you would still be in that setting. So what matters is the difference that you're making. And that helped me think more so about, again, why I chose my career and the implications of quitting. And I knew that hospitals and patients needed all the help they could get. But like still, nonetheless, going to work does cause some anxiety and dread. And obviously it's not pleasant to see people struggle. But thinking about it now, like I personally see this as a test. So I feel like if I can get past this, then like I definitely made the right career choice. But with that being said, obviously people will come out of this and realize that nursing isn't for them, or that they want to practice in various different settings, and that's okay too. But I personally feel like I made the right decision, and at this point, I'm glad that I can still contribute and do my part, and that I'm still healthy. So yeah, being at work is comforting at times, especially because everybody at work is going through the same situation, and it's the one time I can leave my house. So it's nice to just be able to like talk and joke and reflect with the other staff, like nurses and aides, about our experiences together. So that's really nice.
I am so, I'm always proud of you, Faith. So thank you for stepping up and doing what you're doing. We're really proud of you. So, Donna, right now you are senior clinical compliance consultant at Brigham and Women's Hospital, and you have been reassigned to a COVID hotline, and then sending patients to the appropriate direction for care. Could you share a little bit about what you're doing and what your day-to-day is like right now as you've shifted from one role to the other?
Certainly, and thank you for having me, Dean Thompson. I think that what I usually do as clinical compliance is I really try to help the hospital understand what the Joint Commission wants, what the Department of Public Health wants, what CMS wants. And once CMS granted, they call it the 1135, which allowed us to practice quite a bit in virtual care, is the bottom line. And it's all related to COVID, so you can't do virtual care. Everybody can't just do virtual care now. Right now, it's just COVID based on what they said. I said, okay, I got a lot to do. And they called me the next day and said, Donna, we need to change your job. Can you go and be on the telephone line, which is the first part of really virtual care. It's virtual phone line to assess a patient who calls in with COVID symptoms. So off I went to Somerville with, first of all, I was just doing patients, whereas ARC Health was a whole other part, and then nurse practitioners giving results was a third part of the entire building in Somerville that had people calling and taking calls. So they taught me basically how to use Epic, because I haven't done patient care for a while. So there wasn't any Epic. I used to write my notes by hand when I was in patient care. And they taught me how to basically assess for the symptoms and then to try and put somebody in the right place. Whether that was actually at the beginning, we had everybody staying home. And unless I thought they needed to go right to a respiratory clinic or to the emergency room. And within a week, we started just testing many people. And then the other thing that happened was the whole large population areas of such as Chelsea, we're seeing a lot more illness. And so they really just had us taking calls, and then Mass General opened, so I'm with all the partners, so it's all the facilities. Mass General opened a facility in Chelsea, and the next day they had to open one over in Roxbury, and it's just been getting larger and larger. And this is all really because we're able to just open a clinic when we need to open a clinic with what the president has put through with this 1135. So when we take the calls, basically we assess the patient's symptoms. We have a list of things we have to ask them. One of the big things, we don't really ask them this way, but we ask them where they live, because the homeless population is much higher in their COVID, in having COVID. And if they have any other illnesses besides their COVID symptoms, such as fever, temperature, and respiratory problems. Have they got asthma anyway? Do they have ARDS? Do they have organ failures, kidney, dialysis? Because yes, it's not good that those patients have COVID, but we put them in a whole different place to get them certain treatment. And heart disease patients. And it basically, for me, this position has brought me back to my nursing career with patients. And when you think of virtually virtual assessment is really kind of one of the biggest things. There's 4 parts to that, but the first part is virtual phone to phone. I'm on the phone with the patient. I'm not looking at the patient. I'm not listening to the lung sounds. But when they start coughing, I'm thinking to myself, okay, that respiratory, that cough, I'm on the phone deciding what's happening with them. So it's been quite challenging, but it seems to be working well. Once we figure out what they need, we then decide where to send them. Now we tend to be able to send people for COVID testing, the nasal swabs, which is in quite a few different places. And then if positive, they get taught often to just stay at home. And if we feel they have a respiratory illness, we have set up respiratory buildings pretty much all over. I have a big address of places that they need to be physically listened to or a chest x-ray done. We have them do that. And I have, thank God, only sent one patient to the emergency room that I was like, should I tell her to call? She's at this apartment by herself. Should I have her call 911? And she said, no, my neighbor said he would bring me there. I said, can he take you right now? She said yes. And she went in and the other nursing part of me is I follow up on everybody a few days later to make sure they're okay. She's back home. So that was good. And I have one person who was admitted that we were concerned about, but most of the patients are home.
Mm-hmm.
And it's very interesting listening to Rhonda, because today's calls, the calls I had this morning were just stressed people.
Mm-hmm.
I had 2 calls from patients. I tested negative, but I have all these symptoms. What should I do? So nursing wise, you could keep your nursing going and try to assess and make decisions and send them to the right physician or whatever.
Sure.
In that, as we can.
Sure. Can you talk a little bit about this whole
I don't want to say fantastic because I know it's too early, but it's very different. And telemedicine to me, the 4 types of telemedicine is me phone to phone. And what I'm sending people now to do is I communicate with their primary care doc or sometimes just a respiratory physician. If the patient has an email and a computer or some type of an email address to put on their phone with the physician, we're setting up being able to interview them at home for an appointment. I have one person that I spoke with afterwards. They were on the phone for 2 hours. That's a long time for somebody, a physician. And I know that the physicians can also bill for this, and that's a good thing. So the virtual phone/computer visits is the other part. What I remember, the 3rd type of virtual is really a physician to physician. So I go to Haiti and we would have a patient with an issue and the physician would call the physician in the United States and they'd all be on the computer together. Which we're not seeing that for this part anymore, but if we have a problem, they can contact out from, if the patient is far away with the physician, they can call into one of the people in the Boston hospitals. And the other part that just in listening you talk about going to into the patient's room constantly is the other thing we've started. I don't know if other facilities have it as much as it started at Partners 2 weeks ago, is we're hanging iPads in the inpatient's rooms. The iPad is on and maybe the patient's cold. So before the iPad, they put their button on, the nurse had to put all this equipment on and then would say, can I help you? Could you get me another blanket? And then now the nurse can just say, can I help you? And they look at the patient and they can assess them on the screen, and the patient can tell them how they're feeling. And the other big thing for this iPads in the rooms is when they're doing a rounding with, it used to be 10 or 15 people rounding outside a patient's room. They now have one person doing the assessment and the 10 people outside the room rounding, looking at the iPad picture. So it's quite a big thing that's coming up.
Sure. Thank you so much. Dr. Quigley is the Chief Nursing Officer and Vice President at South Shore Health System. Can you, and he's also a member of our Board of Advisors. Thank you for
I'm a big Linda Thompson fan. That's the most important thing.
Dr. Quigley, can you tell us about your day-to-day and how you prepared your nurses to respond to all of this?
Yeah, a lot of themes have already been covered by Joe,
Mm-hmm.
Dawn on telemedicine, Faith on the interpreter stuff, Rhonda and on the mental health issues, and Al on the testing. But I'll try to be succinct. There are 4 things that really dominate our days today. I think probably about 45 days after I had a weird situation where I don't take enough time off, and my daughter was in the Galapagos, so for a semester abroad, so we flew over the Galapagos. There's no internet, so I'm only at Galapagos for 7-10 days. When I hit the mainland back in South America, in Peru, I get 1,200 texts, and COVID had been bubbling, but it hadn't exploded. So when I get back to the mainland Peru, and I get thousands of emails and texts, like the world had changed. So, and then I went right into incident commander role for 2 weeks. So I think that we worked straight, probably 12, 14 hours a day for 45 or 50 days. We now are starting to really see some of the negative impacts of working like that without a mental health break and forcing people to take time off. So but we set systems up that really dominate my day. To answer the question directly from Linda, my day really revolves around 4 main issues. This is Maslow's hierarchy applied to COVID, right? So it's staffing, PPE, testing, and mental health, right? And so what we do is that we're in the process now. The hospital is full, but losing enormous amounts of money because we stopped doing elective surgery, and that really essentially was the margin that created that. So we're in a weird spot right now where we've redesigned the hospital and built it up into a COVID hospital. I think we had the 6th highest. I think the BMC might have had number 3. So we had the 6th highest amount of patients. Our number of patients has dropped from 140 patients a day to about 90 this morning. Our ventilators have dropped from 30 down to this morning was 16. We struggle a lot with the mental health issues and the amount of death that we're seeing. The point that Rhonda talked about with the trailers and stuff struck home to me, and we're having some real challenges with that. So we're doing a lot of mental health support. Drop-in sessions are really, I worry about that, the long-term implications. I loved your question about Faith, about her chosen profession. Because I think a lot of people are going to be asking themselves that, and particularly if there's a second spike, I think there's a whole issue of getting through one trauma, but seeing it coming at you again and stuff is going to be very, very difficult. We really shut down, like everyone else, the ambulatory centers and our surgery, and redeployed a lot of people, which was quite concerning. And I think we did some things well. I could have done some things better in that, and we'll learn that, because I do think there'll be a second spike, and I think a bunch of people are going to opt out that from the first time, and I think that we need to do a better job supporting them. I spend a lot of time right now working on the regional issues. I was doing a lot of this before around behavioral health, because it's a significant gap in our community in terms of being underserved anyway, and that's even more so now. And it's been a particular challenge in the regional side. We were working with 5 skilled nursing facilities, and what we're finding is because of the way this virus hits, and Belle talked about this before, if you look at aggregation of patients and stuff, we have a lot of, the single biggest distinguishing characteristic of the demographic of the South Shore is the number of people more than 85 years old. And a lot of them live in nursing homes. And boy, we have had some unbelievable situations that we're propping up a lot of skilled nursing facilities, independent livings, assisted living facilities, and using nursing, telemedicine, point that Joe and Donna made earlier, enormously well to kind of keep people out of the hospital. There's been a lot of end-of-life discussions that frankly would not have happened before, but we've got a lot of people who have never seen this level of death. I was an ICU nurse and respiratory therapist for a long time, and I wouldn't say I'm used to it, but I had more experience and been supported. But some of these folks are in situations where it's not unusual and stuff. We're seeing about a 20% mortality for folks. If you're on a ventilator and stuff, it's even higher than that. So really difficult situations, and we're seeing a lot of need around that. So a lot of my days trying to figure out how to get patients out now. because
Mhm.
increasingly, people come in, but you can't send them back because their home situations or their long-term care facility is not segregated, or they've lost. One of the interesting things on the unemployment kind of packages is that many of the nursing homes, because they didn't have the right PPE and weren't paying people
Mhm.
well, and a whole bunch of other social decisions that were made before in our capitalistic economy, is they've lost a whole bunch of their staff and they're not coming back. So the ability to stay home and collect an unemployment check and reduce your risk is much more attractive to people than to basically work in a nursing home and basically be at risk and maybe not
Mhm.
have all the equipment. So completely valid, rational decisions that are impacting kind of the hospital. So
Sure.
how do I prepare my nurses for this is going to be your second question. I
Right.
don't know how you could ever prepare anybody for this. I'm old and I've never seen anything like it, man. I've been a nurse. One of the good things about going to UMass Boston is that it's got a strong grit factor. I'm very proud of the grit. There's a bunch of can-do kids that go to UMass Boston. So, but I do think that the people with grit, perseverance and a goal, and don't let kind of initial obstacles get in your way, are going to do better on that. But I don't know how you really prepare. What we've done is over communicate, and the illusion about communication is it's actually been done, right? So we basically here 24/7 do portals.
Mhm.
We have twice a day calls where people, essentially anybody can call in about questions about PP or anything else. And we have a strong magnet organization. It's a 3-time magnet, and we have a very strong shared governance nursing culture here. So it's been spectacular in the senses that you use your existing structures to kind of leverage the channels. So they'll tell you what's working and what's not working, and then we just
Mhm.
listen to them. They pretty much tell us what to do, and my job is to do it.
Sure.
Nurses tell me what to do, and I go, yes, ma'am.
Right.
And that's what I do. So it's been working for a long time, and I think that's the way to do it. But we struggle. Like I'll give you an example. Right now, we're struggling for getting gowns, and
Mhm.
we got a bunch of really bad choices in front of us. But instead of me making the decision as some omnipotent guy that doesn't work in all these different areas anymore, we basically set up all the gowns and say, guys, this is how many gowns, how many days. How do you want to do this?
Mhm.
We have this many thousands, and I'm telling you, some of these options are not wonderful. So
Sure.
we just try to involve the same principles of nursing about, they're smart, they're innovative, and, they solve a lot of problems, a lot of great stuff that, has already been talked about. But they've been very creative, but I worry about their resilience over a long period of time.
Sure. So what do you see happening in the future? How do you see things happening or changing in the immediate
I don't think
future?
we're going back to the way it was. I'll tell you that. I think this is, I think the telemedicine piece is spot on. I also think the amount of debt that the federal government and how we think about fee-for-service medicine, I think that's going to very quickly go to global budgeting, and what that means around population health. Maybe behavioral health finally will get kind of the recognition that it should have. So I think a lot more focus on behavioral health, a lot more focus on social determinants that Val talked about, and others and stuff. So I think that's, kind of a good thing. But I hope, like Joe talked about, we go back and kind of say, how do we, no one likes to kind of, a capitalistic kind of market-driven economy works to a certain degree, but there's a role for government and for society. I hope people vote. That's all I can kind of say. And I hope they vote for the right people, and the right decisions are made over a longer period of time than some of the ridiculous stuff that's happening right now. We are absolutely going to be, and here's my prediction and stuff, not to get too political about the lack of testing here is going to be a haunting issue for us. We're going to have a real challenge for a long period of time because of some approaches or lack of that. I was psyched when Val talked about how she got her site up on Tremont Street. When we didn't have one, we got one up, I think, the first week of April and stuff. But it was a battle. Everybody wanted testing, but nobody wanted it in their backyard. That was a nice NIMBY conversation. But we slammed through a tent and got that up. But if we didn't have our own testing capability, we wouldn't be able to do anything. You can't really do anything. So if you're trying to really serve a community and stuff, I mean, that's going to be a real challenge, on it. So I don't know if I answered your question on that one.
Sure. So, Joe, I just wanted to give you some time because I know you have to get off at 2. If you can share some of your insight or thoughts on what do you see changing as we move forward. You're on mute.
Yeah, okay. We're still getting used to Zoom.
Yeah.
I think that the key things that are changing are what's already been said, that expectations around the role of our healthcare systems in being able to support surges in need like this, it was just never recognized how much we need to plan. The U.S. government's been working with us for years on developing the capability to support surges and disasters, but still the scale has been way too small. We're just undertaking now for what we say the next pandemic, a work on building a multi-casualty way to identify injuries utilizing ultrasound. And it's a contract we just started with BARDA. And I think this kind of sort of anticipatory planning is going to be necessary, and it's going to need to be done on a bigger scale. I don't think we can anymore ignore the fact that there aren't enough PPEs in the national stockpile. I think that needs to be dealt with. And even though there were many voices out there for many years saying this is where the bottlenecks will be in care, still they weren't addressed. I think the change that will happen will be a real countrywide surge in support for building the capability to deal with these kinds of things, so that frontline healthcare providers aren't trying to decide whether they throw that gown away or not, or whether we need to reuse the N95 for 5 days, or put it in a paper bag. Those are decisions that people shouldn't have to face, and I think everyone agrees now that needs to change. I think there's also a bit of a resurgence, even in the face of all this, of pride in the professions of healthcare. I think that people who are in this work realize why they did it, and that's the only way you can get into work in the morning, is if you realize how important this is, and that makes me proud to be part of the profession.
Mm-hmm. Well, I know you're going to have to get off, but I want to just first say thank you so much for what you're doing and your contributions to the profession, and thank you for being a UMass graduate. So we're proud of you.
Thank you. I'm proud of UMass Boston as well.
Okay.
Thanks for having me.
Oh, sure. My pleasure. Rhonda, I wanted to ask you to pipe in on what you see how mental health is going to change as we move forward.
Well, I do believe that it was already, we've talked about the telemedicine piece. It was already starting to change a little bit. We had been talking about it within my practice for maybe the past 6 months. So my patients were already aware that we were going to make that available to them. So that piece we kind of already talked about, but I think one of the things that will be different now is the creativity piece in medical care, and that we can think outside the box. I know that some of the legislature and some of the people that I've been talking to, and my practice is in New Hampshire, but I'm right on the border, is that healthcare doesn't necessarily need to be micromanaged. Our 99214s look like our 99213s, and that the coding and all of that we should be allowed a little bit more leniency in how we are treating our patients. And I do think that is going to change. It's definitely something they're talking about in New Hampshire.
Mm-hmm. Okay, thank you so much. We got so many questions from the audience who registered for this event. And so what I wanted to do was to ask, to pose to the panel some of the questions that I got in advance. So the first question is for Dr. Quigley. Okay, so how are hospitals handling and treating patients that are coming in for a reason other than COVID-19? What is different about their care and treatment now?
That's a great
So-
question. So let me, we're concerned that people aren't coming for care. We've seen enormous drops in what we think are chronic conditions that need to be treated. It's mentioned already, heart disease and some of the vascular diseases and other things. So we are reaching out, big marketing campaign saying we're safe. And what we've done is really separated the hospital and the processing into two areas and stuff. You show up and we're assuming, like on elective surgery, we're screening people without patient testing. It gets back to the point that was made earlier and stuff by Val. If you have your own testing, you control your own destiny. If we didn't have our own testing, we wouldn't be able to do elective surgery and screen. We're now screening all C-section moms. If we had more testing, we'd test everybody who was delivering vaginally also. There's a study out of New York that's showing about 14-15% of moms are asymptomatic carriers of COVID. So we've already had to separate. We've had a really interesting, we deliver about 3,500 births a year, and we've had to really work in the OB area because what we're seeing is essentially COVID positive moms delivering COVID negative babies, and how you provide that care has been a real challenge, and making sure that the baby's safe and mom's safe as she recovers after her birth. So we've really split the hospital and the whole health system into two different kind of virtual pipelines and stuff, with a lot of upfront screening, like Donna talked about, and then a lot of testing along the way. But more work to do because the volumes are significantly down, and we worry about that long term.
Sure. Donna, could you respond to that same question about non-COVID-19 patients that you're seeing in your institution?
Yeah, so I only am going with the reports that they give me every day, as I'm not able to go into the institution. But basically, what they've done is they've just taken certain sections of it, just COVID patients, and then the other sections are as is. But as Dr. Twigley was saying, that they are not. There's not a lot of previously planned surgeries and that type of thing happening. This week they did a meeting, it hasn't happened yet, how can we roll out and get patients to come back? And I will say on the phone line, I'm getting calls this week from patients who are saying, I don't really want to go to the hospital, but my doctor told me that I should go. They should go. I also had a 92-year-old who has never had anyone in her house. Her son brings her food, and she called me because her son said she had to because she was having trouble breathing. So, okay, I do the assessment. And when I'm done, I said, she's got some type of a heart failure or something. So I said, I want you to go to your doctor and I can do that virtually. She said, what do you mean? I said, I want your son to call me and we're going to get you some type of a computer because you need to go in. So it's just, I think in-house, we need to grow the amount of patients that are coming in, but the patients psychologically have to be comfortable. Another call today from a patient. My doctor said I have to come in. I'm not coming in. How should I come in? I said, you're going to come in with your mask on. Everybody in the hospital has a mask on. You need to go to that appointment. You need to have that test done. And I just think people have to just stay positive with the patients is the bottom line.
Sure. One of our alumni asked this question, given what you have experienced, and I want all of you to pipe in on this, given what you have experienced over the past several months, could you share a high point or a story or a moment that made you proud of to be a nurse or the practice?
I got a bunch of let us know. I don't want to hog it, so.
So why don't we start with Faith? Share a story.
Yeah, okay. So, I mean, obviously this whole experience has a lot of pretty memorable moments, but more recently, I guess last weekend while I was at work, and so in our break room, we have this bulletin board that's like a gratitude bulletin board. So like it's where staff can like post notes to each other, thanking them for help, or like if family members send in cards, we hang them up there. So this past weekend while I was on my break, I was just like looking at the board while eating, and I saw a really nice card from a patient and his wife, actually, because they were both on my unit, and they had gotten discharged while I like wasn't at work. But it was just really nice, like reading the card, because they were really specific in like what they described in the card, And it's just like things you do normally at work from like a day-to-day basis that you don't really think twice about, but it just emphasizes like the fact that they remembered that, how much of an impact I guess it has on the patient, and like how much of their interactions they remember. And just like the card was really nice and touching, and they bought my unit lunch that got like delivered with the card, so that was really nice of them. But yeah, that was one of my more recent memorable moments.
Sure. Valerie, why don't you share a memorable moment?
Oh, well, I gotta tell you, the level of teamwork at my practice is amazing. I'll say a couple months ago, we're not really doing all the telehealth visits and not too strict about the mask, but things have been really getting worse. So I noticed that our team supervisor would volunteer to see some of our same-day high-risk patients instead of like letting us, like myself and another provider, her name is Jasmine, after reading the triage notes. So, and I asked him 2 days later, and I said, why are you seeing our high-risk patients? And he then replied with a smile, saying that Jasmine and I, we have babies who needs their mummies healthy to take care of them at home. And then he said he has seen it all already. And I know that for some people call us heroes, and I have to say that my supervisor, he's my hero and my role model, because that so many people are showing that, oh, they gotta take some time off, they cannot like go see your patients and take care, stay safe. But he thought of us, thinking that we need to be safe. Me and Jasmine, we have those babies, and that really touched me. And it's a bittersweet story because now he has pneumonia. He's getting treatment. He's admitted, and Jasmine and I, we are still okay. We are still standing, and that really, I don't think I will ever forget that moment. And I want to say to this doctor that he's the best, and I believe that everybody will just remember him, and I'm hoping that it just gets treated real fast, recovers, and comes back to work. And that's what's very touching.
Sure, that's a wonderful story. Rhonda, do you have a story?
I feel like speaking to the same thing that the others have is the quality of my team. I was practicing by myself up until October, November, and then the practice really just boomed, and I think it boomed at the right time. I like my practice to feel like family. Every day we're checking in with each other. We're making sure we're okay. We haven't distanced ourselves at all, even though we're virtual. And also the patients, like I like my patients to feel like they're a part of our family. And my team has done such a great job of just kind of extending that family so everyone feels emotionally safe. There's been a lot of really unique things that we've been able to see and do with our patients. I'm very grateful for that.
Sure. Tim, could you share a moment of pride that you want to share about your nurses?
Or I'm going to kind of pander to the audience here, and I asked folks about because you see stuff as you're walking around, but I asked people because we were trying to solicit stuff, and I got 87 items in about 2 hours. But one of the cool things relative to students was one of the students who was embedded on the team, like Faith and stuff, on a unit for a long time, and essentially she had just graduated. And so they had a big, they did a huge kind of Zoom virtual pinning ceremony for all the members of the team. So they did a really nice thing there. And we've done some pretty creative things. I think some of the issues around end of life and getting family connected, also to kind of take a little bit of a riff off what Faith was talking about before, is we had some nurses bringing in the interpretive iPads at the same time as the family iPads So it looked like a computer setup, so we could kind of help some families out at the end of life that English is a second language. So that was pretty creative. So lots of stories like that. Very proud of them.
Oh, sure. So we got a question from Sharon asked specifically for Dr. Hodge. So she wanted to know if you have seen an increase in adolescent visits or in that age group that are struggling with the fear of COVID.
So I would say most of our most recent referrals have actually been adolescents or pediatrics. I would say that because of it's everybody's home, that whoever I'm seeing, it's their role. They're becoming the teacher. They're becoming their parents are becoming the teacher. So all of those transitions, I've started seeing parents that have been noticing, oh, wait a second, I think this might be something. They might have anxiety. They might have attention. That sometimes I'm going to start seeing some of the kids within the family, and vice versa. Parents are reaching out a lot more often, saying, "Okay, I see what they're seeing in school. Can you help me deal with this? I'm struggling with it." So I think, yes, a few more adolescents and children, but honestly, it's really more of like a family unit.
Mm-hmm. Great. So we have another question for you, Tim. So this one is from some alums. A few of them, it's more than one, asking the same questions. And they're asking this question about this pandemic and the increased visibility and contributions of the nursing profession. They see it as a positive. But they want to know if you see a need to increase specialization of nurses for both public health and for infectious disease.
Yeah, that's a tough one. Let me think about that. Yeah, I mean, we already, I think Joe had talked earlier about kind of the investment and stuff, and certainly public health has been underrepresented. Behavioral health has been underrepresented. Huge needs. The infection control nurses, there's already 100 lacking pre-pandemic in the state. So we have 2, and you need 1 for every 100 beds, and we're a 400-bed hospital, and that doesn't even count kind of all the stuff that happens in the ambulatory environment. So I think that you're going to see a huge increase in or discussion, the social discussion about public health nursing. I do think that it'll be quite interesting on as you look at, again, some of these decisions that are made around resource allocation. The school nursing is very much a local school board decision, and public health nursing, unless it's mandated and supported at a structural level, it's going to be uneven. So it really has to even out to kind of have the effect we want, because you see it what happens in disparate communities and stuff, right? Disadvantaged communities right now. If they don't have public health advocating and pushing for stuff, then you're right back where you were. So.
Sure. Valerie, this question is for you. Are you seeing in variations or variability in the number of cases that you're seeing that are for males and females? Are there differentials that you're starting to see among your patient population who have COVID-19?
Well, I see that we have more of males, and they have all these chronic conditions. And we were discussing that at the clinic, and some feedbacks we get is like males are more like careless, I will say, and as opposed to the females, you will see they're all going to the grocery stores, getting like washing their hands, very conscious about wiping all the surfaces, and so that's what we get for males, like and I'm not sure if there's a research like studies about that, but I can tell you that most of my positive COVID patients are elderly male patients. I would say that if I have 10, 7 of them are males.
Okay.
And that's unfortunate to see. And some of them recovered, and the ones that have diabetes, most of them, they passed away. So that's what I realized.
Okay. The next question is a question I'm just going to pose to, it's for me, and for Donna and Tim, I want you to pipe in on this. But this question had to do with how we've had to change our teaching modality for this semester, and maybe it might have to change as we move forward. And one of them was concerned about licensing, but the other question had to do, how do we begin to shift how we do clinicals as we move forward in the future because students missing them? But then how do we support these students who go into become a nurse for onboarding? One of the things I just have to say about the testing, all of the deans in the Commonwealth of Massachusetts wrote a letter to the governor asking if we could, if they would look at the pass rate for colleges to, there may be a shift downward just because a lot of the licensing places are closed. Them trying to figure out how to do social distancing. The testing company that does the test is working on trying to shift this. And as we need to do social distancing for the testing in the future, it may delay the amount of time that it takes for students to test. So we just need to be a little bit more mindful that this group may have some differences, and we've asked to have some forgiveness for a year from the date that we had to close our clinical experience, and that was in April. But I did have a conversation with your CEO, Tim, about onboarding of students for the future. So, and Don, I'd love for you to think about how do we onboard these students who are moving to become nurses, and they will graduate. They will graduate in May, but how do we ensure that when they come to your facility that they're competent? How do we do that? So I'll start with you, Donna, and then you, Tim, can fill in.
I think that one of the big things is the students have a lot of simulation learning already when they do in their laboratories, which is awesome. And that then the best thing is not then go to the hospital and be able to work with the patient. But I do think that these iPads in the patient's room will help the students learn. As far as, I'm a hands-on nurse because I'm old and I like to just have my hands on. But I think that with the method of doing the computer, everybody being on the computer together, I do think that they can also continue to learn from each other. And that right now they're not having the students in the facility, in the hospitals, or at least not in my hospital, because they just felt it was too complicated for the scrubs and everything that needed to be put on. We are learning about that every single day, and it's going to, I hope, change. The students have to do hands-on training, not just simulation. And the nurses also like that. They like to be with the student who is helping them, but also learning as they go. So I just think I really think it's just time is going to hopefully get us back on the saddle in the right direction. But there will be a lot of changes.
Sure, thank you. Tim, you want to speak to this?
Yeah, I think Donna hit the highlights on it. I do think that we're going to have to continue to look at our dedicated education unit and scale those up, because that's a different kind of longer term investment in people to really support, teach them. I do think that we're probably going to have to extend precepting. I agree. The content, people are smart. They can learn the content. Applying the content and putting all the pieces together that's the art of nursing, and it's going to take a while to do that. But I think that we need to maybe think differently about how to support our preceptors so they can in fact support new incoming grads. And I think that I'm expecting that to be longer. And we've talked about this anyway. I think that's the way things are going to eventually move anyway. A lot of content can be learned online. The application of putting it all together into a beautiful choreography and stuff that takes experience or applied experience. So I think that it's much more. It's more an issue of how the organizations change their processes to support the student as opposed to what the student has to do. So I think some preceptor work on our side is coming.
Sure. You know, one of the questions that a lot of our students have asked me, and I want to turn this over to Faith to respond, a large proportion of them chose to go to work. They're working as patient care technicians or certified nursing assistants, just like Faith is doing right now. How do we use these smart, and you can see just by listening to Faith that she's a smart young woman, how do we use these smart young women and their paid clinical experiences to at some point be looked at as some clinical experiences that we can provide? You know, are there ways that hospitals can begin to partner with universities to devise some kind of quality improvement projects that they are able to do for you within the hospitals to augment the paid work that they're currently doing? So Faith, you know, I'm just getting you to chime in terms of at that student role, how you see your work right now as a nursing assistant and your education as a student, how you can fit those two in and how the hospitals can support you.
I mean, I do feel that, especially like for the setting I'm in now, I guess, I still do like learn a lot of things, especially when I'm at our satellite location. And like I literally, like someone was explaining to me dialysis and like chest tubes last weekend while I was working. So I think there is definitely an aspect, as long as like Tim mentioned, as long as we have nurses willing to like teach and educate, like I think that could definitely be devised, and like lesson plans can be designed around that, where student learning can be augmented. I just feel like possibly for specialty courses, obviously that would be like a different story when it comes to like pediatrics or maternity based on where that student's located. But for general, just like touching up on nursing skills, and even patient communication is a skill. And like even when it comes to mental health, like I might not work on a psych unit, but mental health is something that all nurses deal with. I feel like that could definitely be applied and integrated into various different types of units and clinical settings. So.
Thank you so much. Tim, you have any thoughts?
Never disagree with Faith is my thought. She's spot on. She's got it. I mean, I think the mental health aspects of, I'm a critical care nurse and respiratory therapist by background, which kind of is another way to say is more science-based than, or I would say quantitative than the qualitative. But I do think that the older I get, the more important to be able health aspects are apparent to me, and I do think that we need to spend a lot more time on that, and not just in our teaching, but our organization development and support. Because I think at the end of the day, if you don't do that, you're going to lose some really good out of nursing.
Sure.
So.
Donna, you have any thoughts about that?
All right, I just want the nurses to just keep learning. I mean, for me, with all my years of learning, when I sat in Somerville with all of these, they were very far away from each other, nurses on the computer talking to the patient, I'd say to the patient, hold on. And I'd ask the nurse beside me, what do you think? Everything we do as nurses is constant learning. So I hope we'll want to continue teaching. And we do.
You know, we probably could only get one more question in before we have to close out, but several alums have asked about the vulnerability in these long-term care facilities and nursing homes. How do we what should the nursing profession do in order to deal with this vulnerable population? Because it's becoming so much more evident that there's something that needs to change in these facilities. And anyone can respond.
Again, I feel like I'm speaking too much. I spend 50-80% of my time on that one. And that's, I think as nurses, we need to take the leadership role and push the system and have that social dialogue. I think the virus is particularly difficult for patients with coexisting diseases, and they've done heroic work with a lot less support than the hospitals. The hospitals certainly have done great work, but the SNFs are doing the same great work with a lot less resources, and deserve more credit. So I do think there has to be a conversation about quality of life and what it means to live a good life, and as well as what the staffing and support. If you are essentially, a lot of this is payer mix driven and it's socioeconomic. So if you're on Medicaid, you can't run a nursing home and pay people enough to be viable. So I think that really gets to the social issue.
Yeah, I want to give everyone just a quick, some time, some last thoughts. Rhonda, I'll start with you.
I think from all of this and listening to everybody talk, one of the biggest things is that that in the community, in the nursing community and healthcare, that we're all supporting each other too, because we speak to the mental health being really the basis of this, being right at the gut of the issue. So I think it's just really important that even all of us on the panel and everyone who's listening, that we're there for each other. I think that's important. Donna?
I think that I'd like to find one positive thing every day that happens. And yesterday, and hopefully every day this summer, I cannot believe the amount of children out playing in their yards with their parents, not with the rest of the neighborhood, but the neighborhood, the kids across the street or next door, they're yelling to each other. We just haven't seen that for a long time. Kids are off doing their events, which are awesome. I hope they all get to do their events. But that the neighbors are also supporting each other and helping each other. It's a good thing.
Yeah, Faith?
Yeah, I think everyone said great things. And I think it's important that we just keep talking about our experiences and talking about things that we see work for our various facilities and what isn't working. Like, I've heard a lot of great suggestions just hearing from the panel today that I feel like I'll definitely take back to work. And ultimately, I feel like just talking about it also helps like blow steam and helps you like stay in a great place and build that community and connection with other people, especially like with people in your profession, whether you're a nurse, doctor, whatever.
Valerie?
Well, I think that we still need to keep the teamwork in place, and also check on our patients that we don't hear from a lot, because I feel like the ones that are quiet are the ones that we really need to give a call.
Sure.
Also be mindful about the cultural differences too, because some people that don't, it's just really understanding the cultural aspect of it, because I am from Haiti and I can tell you that that's what I am dealing with right now. And I try to call all my friends because I know that they are dealing with it a different way. They're very quiet about it.
Yeah.
They don't tell us how they really feel.
Sure.
And you just tell them, just checking on you. And then that makes a big difference.
That's great. Well, I want to thank all of you, and thank you in the audience for attending. And this has been a wonderful opportunity to hear from our alums. So
thank you.
Great.
Thank you.
Thanks.
Thank you
All
very
right.
much.
I appreciate it. Bye-bye.
Bye, Linda.